Okay, well, thank you very much. It's quite easy for me to sum up this meeting. Wow, right? I think all of us feel that way. It's been really a tremendous 2 days, and I have the honor of summarizing today's fantastic presentations that we've had. By the way, don't forget to follow AASLD President on Twitter. That's a shameless commercial, okay? But I already posted some pictures from today, so please join us. Here are my grants. I just want to thank all the authors who shared slides for this summary. So we started the day talking about hepatitis B and its impact on public health, and Professor DeShaco mentioned that we still need a better understanding of the disease and the disease burden around the world. Awareness overall for hepatitis B remains much lower than it is for HIV disease. Treatment is important for control of hepatitis B, but a very small percentage of people globally have been diagnosed with hepatitis B, and even a much smaller percentage, estimated to be only about maybe 5%, have actually been started on treatment appropriately for hepatitis B. And here, unlike with hepatitis C, drug costs don't seem to be the issue. It seems to be more about awareness and a public health imperative to get patients with hepatitis B treated. Vaccination has been widely accepted in many countries, and we've done quite a decent job of increasing the number of patients getting vaccinated. But we're still making unsatisfactory progress in some parts of the world for screening, diagnosis and testing and appropriate linkage to care for hepatitis B. So we still have a way to go in terms of improving public health. We've learned from Professor Butti that, of course, the benefits of achieving viral suppression have been very well documented. Patients, we've learned for many years that with decompensated cirrhosis can be dramatically improved with hepatitis B treatment, and that long-term nucleoside therapy is generally considered safe. We may see some modest changes in GFR with long-term tenofovir treatment, and a smaller decrease has been noted with TAF. And we see similar relationships with bone mineral density, suggesting that TAF and entecavir are recommended for patients with increased risk for renal and bone disease. Professor Lampertico tackled the issue related to the importance of nucleoside and PEG interferon combination therapies. This has been debated for many, many years, and while there's a strong rationale for combining PEG interferon and nucleosides, many different strategies have been assessed over the years, and most studies are consistent in that they show an improvement in quantitative surface antigen decline, but none of these have really translated into long-term clinical benefits, such as functional cure consistently. So for now, combination strategies are not routinely recommended by EASL, but may be applicable to certain patient populations who have some favorable baseline and week 12 predictors of response. We had a very spirited discussion about stopping nucleoside analogs, whether to stop or not to stop. Professor Manja, I think we're all in agreement that there are certain populations where, particularly in the E antigen positive group, that demonstrates seroconversion in a non-cirrhotic population, stopping after consolidation therapy is appropriate, and this is consolidated within the 3 different guidelines for the most part. The E antigen negative group is still somewhat controversial on whether those patients should be stopped, should have their nucleoside analog stopped. And we have to recognize that if you are planning on stopping, these patients certainly are at risk for flares of their disease, and sometimes these can be serious and even fatal. So the decision to stop should not be taken lightly, and patients must be monitored very closely before considering discontinuing a nucleoside analog. And similar discussion and agreement was held by Professor Parana that there are certain groups that may be consistent with stopping nucleoside analogs, particularly the E antigen positive group, but he really felt that until we have better predictors of relapse, stopping nucleosides is not the way to go, and that we need randomized trials. And I think this is one of the big laughs. We all recognize that there are many other things we want to stop, including climate change and Brexit, so we should focus on those instead of nucleoside analogs, as he so aptly pointed out. Professor Asala gave an excellent review of mechanisms and potential targets for the treatment of hepatitis B. He defined the goal, of course, the ideally functional cure, and the aspirational goal of sterilizing cure for hepatitis B. He discussed many different targets and provided data about some of the promising drugs that are in early phase clinical trials. And we're very hopeful that those drugs, combination of those drugs, will achieve the goals that we all hope to see, similar to what we achieve for hepatitis C. The use of quantitative hepatitis B surface antigen is not universally available. In the United States, for example, we still do not have a routinely commercially available quantitative assay. But as Professor Brunetto recommended, there are many situations where this can help tailor the treatment for patients with hepatitis B, that the levels of hepatitis B may be a major diagnostic tool for trying to manage some of these carriers. There's a demonstrated role in quantifying the likelihood of response and the futility of continued treatment with PEG interferon in certain patients, and that low surface antigen levels may be able to predict off-treatment response after cessation of nucleoside analogs as well. So this has been studied for many years. We still are waiting in the US for these particular assays, which we hope will come shortly. Delta hepatitis, Professor Brunetto stepped in and provided a lot of important information about Delta, which still remains a very important unmet medical need. We know that PEG interferon can help maybe about 25% of patients with Delta hepatitis, but there's a high rate of off-treatment failure. Interestingly now, there are several promising agents under development, and they're evaluating different targets as shown here. But it continues to be a major and unmet need. Every day we see more patients with Delta hepatitis, with decompensated disease, with hepatocellular carcinoma, and we look forward to these large-scale trials that are underway now. Treatment during pregnancy, we've made great strides in consolidating guidelines for the treatment of preventing perinatal transmission. Professor Lim described, which may have been underappreciated, that hepatitis B can complicate pregnancy for the pregnant woman, not just for the unborn child. AASLD and EASL and APOSL guidelines are fairly consistent across recommendations for testing of hepatitis B, vaccination, routine use of HBIG, and starting antiviral therapy in the third trimester, with only differences related to the level of HBV DNA at which you might consider starting third trimester prophylactic treatment to prevent maternal-child transmission. And of course, stopping antiviral therapy still warrants close follow-up once those patients discontinue treatment, anywhere from 4 to 12 weeks postpartum. In the middle of all this about viral hepatitis, we had a very interesting lecture from Professor Boyers about the management of cholestatic liver disease, really the state-of-the-art lecture. He discussed the pathophysiology of PBC, including interesting information about disordered bicarbonate activity in cholangiocytes contributing. He discussed the mechanisms of UDCA as the backbone of continued treatment for patients with PBC, and that those that respond have an excellent prognosis. Patients who don't respond in treating with OCA also demonstrate biochemical and short-term benefits that need to be confirmed in long-term studies, and we're starting to see an increase in bezafibrates being utilized in this population of non-responders. PSC continues to remain an unmet medical need. While UDCA has been shown to have some modest benefits, there are still most patients who are not responding in long-term to PSC, and experimental therapies are clearly needed, and some are being evaluated as well. He discussed things to keep in mind related to IgG4. Seeing it in older males, there's a specific pathological definition, and PCR-based testing may be possible under certain circumstances. And interestingly, that this may be associated with environmental exposure, so we may be learning more about that in the near future. Professor Paradis talked about the influence of NASH as now becoming the driving force in hepatocellular carcinoma, replacing, of course, hepatitis C. We learned some very interesting aspects of the pathogenesis of steatohepatitis and HCC. Diabetes, obesity as independent factors related to hepatocellular carcinoma, and cofactors, of course, such as alcohol playing a major role. I think one of our major concerns now is that we are, as she reported, seeing HCC in non-cirrhotic patients with NASH, which raises many unanswered and frankly terrifying questions as to what screening recommendations do we make for the general population with NASH. Professor Gali talked about and tried to harmonize the guidelines for the treatment of hepatocellular carcinoma across AASLD, EASL, and APOSL. No small task. All guidelines agree that screening with ultrasound, with or without alpha-fetoprotein for patients with cirrhosis at risk for hepatocellular carcinoma remains really important and foundational for us trying to manage hepatocellular carcinoma. Use of biopsy for suspected HCC should only be done very sparingly. Treatment recommendations do vary by region for guidelines for different stages of hepatocellular carcinoma, and the optimal therapy for HCC remains controversial and will likely continue to evolve as new therapeutic regimens are incorporated into the algorithms. And of course, we should not forget to drink all our coffee, which seems to have benefits across all liver diseases. In light of that, Professor Sangro talked about some of these new therapies for hepatocellular carcinoma, and I think all of us could feel the excitement with these new drugs coming down. For the first time, we can offer patients new potential, while not curative, but at least potentially improve their long-term survival. So we're making remarkable progress in therapy for advanced liver cancer. Kinase inhibitors have a consistent track record in improving survival, and these new second-line therapies for patients who failed agents such as sorafenib are becoming more widespread use and demonstrating their utility as well, such as other kinase inhibitors. And perhaps most exciting is the immunotherapies that are coming down the road that are representing some new therapeutic options that have demonstrated prolonged survival for many patients, and will need further testing as well. Dr. Turow, of course, gave an excellent presentation about the changing face of liver transplantation. Hepatitis C is becoming less of an issue, except in the setting perhaps of hepatocellular carcinoma. Alcoholic liver disease, NASH, of course, becoming the major impact. And as she demonstrated, recurrent diseases post-transplant, particularly NASH, are going to be extremely challenging for all of us to manage and will have major impact on the long-term survival of our patients. And finally, in the last three speakers, hopefully you heard their summaries, so I'm not going to spend any time. They were fantastic. They gave us a lot of pearls on the management of patients with end-stage liver disease, Professor Durand, Professor Godano, and as well as the very controversial topic of transplanting patients for alcoholic hepatitis, Professor Maturan. So again, I would like to thank all our speakers for today. It was a very engaging day. I think we all learned a lot. And as usual, Patrick, a phenomenal meeting, and until next year, and I hope that translates to French appropriately as well. So thank you very much.